Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI podcast with me, Dr. Andy Cutler, and today we're talking about a particularly pernicious disease, and that's bipolar disorder. It is protean, it is heterogeneous, it is difficult to diagnose. There's many challenges in treating it, and I can think of no one better to have this discussion with than my very good friend, Dr. Roger McIntyre. Roger, how are you?
Eddie, great to be with you. Always enjoyable to have this conversation, kind of a fireside chat. And yes, we've had this conversation before. This is a conversation that I think is one that's not just enjoyable, but one that we continue to, I think, evolve, because this area is changing so quickly in bipolar disorder.
It certainly is. And you have really done a lot of work in this area. You've published some really important articles that have moved our knowledge forward. And I'm going to start out with just making a recommendation to our audience that they read your magnum opus, is what I've jokingly called it to you before, which is an article just called Bipolar Disorder, published in The Lancet in 2020. A real great review, sort of state-of-the-art review of what we know. But let's get started with what I think is the biggest challenge, really. I think the challenge to bipolar is recognizing it. And yet we have DSM-5 criteria, but Roger, why is it so hard to make the diagnosis? Why don't we just follow the criteria?
You know, there's a couple of suspects that are responsible, I think, for this. I think partly Mother Nature's to blame, Andy, in the sense that for many people who have bipolar disorder, the initial declaration of the illness is depression. In fact, we know that polarity depression isn't just predominant in bipolar, but for people who are living with bipolar, when the illness goes from the pre-symptomatic to the symptomatic phase, those early symptoms usually are depression and anxiety. And so we wouldn't necessarily know that the person has bipolar disorder unless that card of mania or hypomania that Mother Nature has is taken out of the back pocket and it's shown. And for many people, that's not shown for maybe 2 years, maybe 3 years, in many cases, 10 years later. So in other words, we need to always be vigilant about so-called latent bipolarity or transition to bipolarity. But I think that's one piece. In other words, the phenomenologic manifestation, the early declaration. The other part, I think, Andy, and this is also something that I've observed just as a clinician in this area for a long time, is that more and more, we're seeing less of the so-called classic euphoric patients with elation and grandiosity. And in a paper I wrote a few years ago, and this is a different paper, I kind of asked this rhetorical question: where are elated bipolar patients gone?
Yes.
And it's only meant to make the point that I think it's changing, and we're seeing more mixed, more anxiety, more irritability, more hostility, and that doesn't necessarily, for a lot of clinicians, alert them to bipolar. So I agree with how you preface it. I think that there's many modifiable deficiencies in bipolar disorder today. I think the number one is getting this diagnosis accurate and getting it correctly. So I think these are two factors. I think it's really just the phenomenologic nature of bipolarity.
Yes. Well, Roger, I actually think there's a link between those two things you've said, and that is I think that we focus so much on the depression. And we have, over the past, 20 years, gotten so good at teaching primary care how to use antidepressants that we're bathing the bipolar brain in antidepressants. And that is part of what I think is changing the face of the illness. And that, probably coupled with the potency of drugs that people use, I think that you're 100% right, that there's a lot more of this. It's changing face.
I agree with that, Andy. I agree. I agree with you. And I do wonder that myself, whether the prescription and the administration of antidepressants for some people is changing that phenotype. We have a colleague, Rif Al-Malak, who has this wonderful acronym called ACID, antidepressant-induced chronic irritability dysphoria. I think that, we as clinicians are often very concerned about antidepressants inducing mania or hypomania. The actual number needed to harm is close to 200. That doesn't happen very often. What typically happens, I think Rif caught it perfectly in his acronym ACID.
I agree.
Is that some patients, I call it dysrhythmic mood instability. Some patients the antidepressant almost amplifies or exacerbates. It maybe even engenders this sort of sort of dysrhythmia to them, and they feel very chaotic. And then we as clinicians just assume, okay, this is depression, anxiety. I'm going to get more antidepressant. As we often do, to only make matters worse.
Right. Now, the other problem, of course, is we don't have a blood test or an X-ray. So it's a clinical diagnosis. And of course, the sine qua non would be getting a history of a manic or hypomanic episode. But we all know you don't get that very often. Either patients are not accurate historians or more likely, I mean, Roger, who wouldn't want more confidence? Who wouldn't want more energy? Who wouldn't want to feel like the smartest guy in the room? Well, that's hypomania. I'm not going to report that as pathology. That's my goal. It's how I want to feel. And I think there's another issue neurobiologically. I think bipolar is affecting parts of our brain that have to do with self-observation, insight, and judgment. So they don't see the trail of destruction they're leaving behind them and the consequences.
That's right.
And so this makes it hard to get the history from them.
Yeah,
and then we're left with then someone who's presenting when they're suffering, which is when they're depressed. And DSM does us no favors. They describe a major depressive episode exactly the same, whether it's unipolar or bipolar depression.
Yeah, that's right. And the other part to this story, and we've talked about this before at the live NEI, not just in the fall, but our synapse in the spring. And that's a concept that relates to comorbidity called heterotypic continuity. Every clinician knows that an adult or, living with bipolar disorder is someone who also often meets criteria for other comorbid conditions, both medical and psychiatric. In fact,
that's so
if
true.
the exam question was posed, which mental disorder is affected most by comorbidity, you'd have to circle bipolar as the right answer. And just to put a little fine point on that, 50% of people living with bipolar meet the criteria for at least 3 or more other conditions. So this is a complex.
3 or more?
Yeah,
Wow.
but here's the part for me, and it's always interesting because it's quite common for this type of narrative. Here's a very common narrative. A patient will come to the clinician for consultation, let's say in their 20s. And what they'll say is, when I was a young child, there was a suspicion I may have had ADHD. I may or may not take Ritalin. I was kind of an anxious kid, struggled a bit at school. There were some behavioral aspects. Got involved in smoking some weed in adolescence. I was seen at college at the student health center for maybe panic attacks. Had a little sort of bout with a little mild depression when I was about 21. Had migraine headaches. Start when I was around 22, 23. And recently I was told I have a low thyroid. Now, so far I've said nothing about mania and hypomania.
That's right.
But when I hear that narrative, that gets me suspicious because bipolar does not begin when you're age 20. There clearly is a pre-symptomatic phase with respect to bipolarity, but people who are at that predisposition to bipolar have a predisposition to other conditions that phenotypically change across time. So I always use the example of Down syndrome. The phenotype is a consistent phenotype across the lifespan of the lived experience. That's homotypic. But heterotypic is when the underlying disease phenomenologic state is changing, but the underlying disease is the same disease. So the phenomenology of the disease is the same. Now, again, I don't think all comorbidity is, in quotes, just a variant of bipolarity, but I think it's not so simple. And I think that often obscures, especially the patient comes in, they're depressed, they're anxious, migraine, they have panic attacks, they're using drugs, alcohol, they can't focus, they got a trauma history. We're like, what? How to make this diagnosis? And sometimes, as I always say, when it's complicated, make it simple. And often you can find that theme of bipolarity throughout this very complex history.
Well, you've just introduced another variable that makes it hard, is comorbidity. That makes it very hard. It's rare to see pure, quote, in quotes, pure bipolar.
Yeah.
So that's another excellent point. And so I think what we're saying is that we well know that the diagnosis, an accurate diagnosis, is delayed by anywhere from 5 to 10 years, depending on whether it's bipolar 1 or bipolar 2. I think it's very clear that from the issues we're talking about why that is, and especially because, again, when you see when patients present as when they're suffering and they're depressed, you're more likely to just say, oh, you have depression. And I think the problem is, another problem we have, Roger, is a semantic problem. We use the word depression for 3 things: a symptom, a syndrome, and a diagnosis. Depression, people say, is really a major depressive episode, is a syndrome. It's a collection of symptoms. It's not a diagnosis. And so then we jump to, I have this great group of drugs called antidepressants. So this is a semantic problem. Everything's depression with antidepressants.
Yeah, absolutely. I agree with that. And life would be easier if there was one feature of depression that was diagnostic of bipolarity.
Right.
And unfortunately, there's not, as we know, as you said, the symptoms are, they're overlapping. I mean, as we know, there's some features that
There are some, yes.
more probable, like psychosis, atypical symptoms, or mixed features. But still, life would be easier if we had a nice blood test for sure.
Yeah, none of those are diagnostic, but I think we have to use our clinical acumen. And so those three things you've just mentioned are helpful. Mixed features, atypical, hyperphagia, hypersomnia, sensitivity, rejection, mood reactivity, and psychotic depression. None of them are 100%. Now, Roger, what are the consequences then of delayed diagnosis, not only psychologically, socially, but perhaps neurobiologically?
This is an area that has been receiving a lot of attention. Just recently, we had the International Bipolar Conference in Iceland, and this was also discussed there. This is very much represented in our peer-reviewed literature that every time a person has an episode, or for that matter, every time a person is left with active symptoms between episodes, when you, as I always say, look under the hood. You look under the hood, look at the brain, look at the body, we are seeing changes. And there are changes which is referred to, the jargon is biosignature. The biotype of depression is changing. And as an illustration, when you look at, for example, pro-inflammation, which is something I've been interested in a lot of time, as you know, Andy, in metabolic disruption, you're much more likely to see what's called a pro-inflammatory balance in bipolarity, which means an elevation of pro-inflammatory cytokines after 3 to 5 episodes than after the first episode. Now, although diabetes is a risk in bipolar independent of medication, we know medications can make it worse, but so can subsequent episodes. And I like to think of mania and depression as really a neurobiological, Andy, you know this in Florida, something about hurricanes. These are hurricanes. They leave a trail of destruction with respect to the neurobiological effect on the brain and body, hormonal shifting, inflammation, oxidative stress. And someone doesn't even need to know the literature. All you need to do is look at your day-to-day practice. When you see a person who's had, say, 7, 8, or 10 prior bipolar episodes, mania or depression, when compared to someone who's in a first episode early in illness, early in life, everybody knows the former situation is much more difficult to treat. And so something, and many patients, we all know this, come back and say, something, that treatment you gave me 2 years ago that worked fantastic is not working as well this time. And everybody hears this all the time. And that's an indirect suggestion of some type of neurobiological change. One final point on that, Andy, we press the point so strongly that bipolar disorder is mania, hypomania, depression, and that's true. But at the end of the day, it really is a chronic illness. And patients have, chronic problems with sleep. Half of people with bipolar who are not even manic or depressed meet the criteria for a sleep disorder. They have problems with affect instability and comorbidity. Here's the point I want to emphasize is cognitive impairment. And that's the principal reason why so many patients can't get their role function back. And every time you have an episode, some studies, not all studies are saying this, but I wouldn't expect all studies to say this. It's science. You have hits and misses. But a preponderance of studies are suggesting that a subgroup of people, every time they get an episode, it's like psychotoxicity. They're getting further loss of cognitive functions, which of course maps onto brain changes.
Yes. Yeah, 100%. So as you're saying, this is potentially a neurodegenerative illness. We're used to thinking of schizophrenia in that way. And I sometimes say, Roger, and I don't know if you like this analogy, bipolar to me is like a rock rolling downhill. It just kind of rolls faster and faster and faster unless we interrupt its progress.
Oh, I think that's very, very true. And for those who are wondering, someone might say, well, if this illness is so progressive, why are we waiting for a 5-alarm fire to happen? Why don't we just intervene much earlier? And I think that point is well taken.
Yeah.
And there has been now efforts in different parts of the world to look at people who are at risk of bipolar on the basis of having a first-degree relative, like a parent, or ultra-high risk. Ultra-high risk would be a youngster who has risk because mom and or dad has it, and also that kid doesn't have bipolar yet, but the kid's starting to show non-specific psychopathology, some anxiety, some behavioral problems, some learning problems. And then to take that at-risk population, which has not declared themselves yet, and say, why don't we try to prevent? Why don't we try to prevent or at least preempt the the declaration. And there's been a variety of efforts looking at psychosocial interventions. I've been involved in an exercise intervention looking at this very issue. But I think this is where the field needs to go. It's a different conversation, obviously.
Right.
But I think much of the damage that's done to people's lives and frankly to their brain and body is fully preventable. So far we're describing kind of a dour story here, but
yes,
I think it is very preventable, and much of this is sort of is hazard that if we would have detected, diagnosed, and treated accurately and appropriately, we would have prevented that. One final comment about this, which I've been very concerned about, is something that doesn't get a lot. Everyone knows that the standardized mortality rate of suicide, ideation, behavior, and completion is higher in bipolar than the general population. Some would make the case is higher than any other psychiatric illness.
Yes.
And we all know that. But here's the part I want to just highlight. And that is when people have looked at self-harm in bipolar disorder, people have made serious injury to themselves intentionally. That type of behavior can occur at any age, 20, 30, 40, 50, 60, any age. But when you look at when they're most likely to do it, it's in the first 10 to 15 years of the illness.
Oh my.
And that is also the window where they're more typically, they're not even being diagnosed and they're not even on the right treatment.
That's
so
right.
I think there's also an interesting, because people often ask me, how come we haven't lowered the suicide rates in bipolar? Well, that's a large question. There's lots to that. I don't think there's one reason. I think there's not one reason at all, but I do think there is an opportunity that's fit for purpose that's right in front of us in the near term. Get the diagnosis detected early, diagnose early, get them on the appropriate treatment. And it would be a really interesting hypothesis. If we can just do just that, we can lower suicide rate based on what I just sort of put together, these collections of observations.
Yeah, and of course, similar strategies being looked at with schizophrenia. But I love your comment here. It's true. We're too often in a reactive posture. We should be more in a proactive posture here. And this brings up, again, the primacy of trying to recognize this early. And Roger, I'm going to run something by you, and you tell me if this is a little bit extreme. But I believe that MDD should be a diagnosis of exclusion. You must rule out bipolar first. Is that too strong?
Andy, I don't think it's strong at all. I think it's actually a point I entirely agree with. And I think, if one was to say, okay, what percentage of people who present to the clinic with depression turn out eventually to have bipolar disorder? Like anything else, estimates vary. But you're coming in around, depends on the study, the age, the demographic, all that. You're talking at least 20 to 30%. That's a fairly consistent range that's reported. Yep. I don't know if this is still the case, Andy. I'm so far removed from surgery, but I recall when I was a student going through my surgery rotations, I remember the surgeons telling me, if you've got, right lower quadrant pain, you got to really be thinking about appendicitis. Now, it's not appendicitis, 4 times out of 5, but if it is and you miss it, that's a problem.
That's right. That's
and so I thought it was, for me, I've always had that sort of example in my head, but
that's a terrific example.
I don't think, look, time is precious. I'm a clinician. We're all time poor. We've got to make so many in-the-moment decisions. Patients bring a fair bit of complexity in other aspects, psychosocial and so on. So we need to be very, very economical with our time. And I do think that it is economical. It's a high yield. It's a good ROI, return on the investment, to take that time just to consider bipolarity at the index consultation. And also later on, if the patient comes back and says, my SSRI is not working, or I've had a sequence of many failed antidepressants, something's just not quite right. In other words, they're appearing in quotes, treatment resistant. That also kind of alerts me to some extent.
That's a really good point. I think that before you call somebody treatment-resistant unipolar depression, you've got to, again, redouble your effort to diagnose bipolar. We're going to get to some strategies and some tools to do that in just a second. One final thing I want to get to before we get to that is, what role do cultural and societal perceptions play in the misdiagnosis? And that would include, of course, stigma.
Yeah, and this is such a big topic, and I think that there is an impact on this. And first of all, we know that the way illnesses manifest is certainly shaped by culture, by economic, by societal background. And we know that in some demographic groups, there may be presentations of psychiatric illness that look a little different than other demographic groups. And I think that that's something we just need to be aware of. For example, we do know that in the United States, if you are someone who is of African-American background or you are of Hispanic background, and you go to a healthcare provider and you tell the healthcare provider something to the effect that you've had a psychotic symptom. Well, Andy, you and I know a psychotic symptom does not equal schizophrenia. It could, but it doesn't necessarily.
That's right.
People who are of African-American background or Latin or Hispanic background are much more likely to be told they have schizophrenia rather than bipolar disorder, when bipolar would have been the appropriate diagnosis.
That's right.
And so we have a cultural, in many cases, racial, and I'll keep going. There's also socioeconomic biases that are taking us astray. We have to be aware of that. And also, I mean, you know, because I've been a clinician like yourself, Andy, for a long time, I do know that in some cultures, I work primarily in Toronto, very multicultural city. If I see someone who's from Haiti or Jamaica or from the Middle East or someone from Africa or Asia, the way that they are reporting symptoms may not be identical to someone who was born and raised in Chicago or Toronto or, you know, LA or whatever. So I think we just need to be aware of that. But I'd always been curious about this bias that can sometimes send us diagnostically astray in some cultural, racial, or other background groups.
Yeah. And also some cultures are more or less open to psychological symptoms, and mental illness is a diagnosis, of course, these kind of things. Some cultures perceive it as weakness and so on. So yeah, all of those things. All right. Well, let's say now I've got a depressed patient in my office that I don't know really well, and I haven't really gotten a clear history of a manic or hypomanic symptom. If there was just a handful of questions I could ask, and we've alluded to some of these, what would be a couple of things that I would ask?
Yeah, I think the key thing for me, and as you know, in life, I guess, in life in general, medicine and certainly psychiatry, you know, there's a couple of events or you know, famous speeches or famous papers or famous events. And one of the famous papers in psychiatry, one was to look at sort of the Mount Rushmore of articles in psychiatry that are just must-reads. You have to read them. Is the famous 1970 paper from Robinson Guzay, you in St. Louis. And for those who may be a little less familiar, this paper written, hard to believe, 54 years ago, described how to, in quotes, validate, end of quotes, a mental disorder. And it's still true today. What you do is when the depressed patient comes in, you cannot take any one symptom and say, hey, because of that symptom, you've got bipolar. There's not anything that's what we call it pathognomonic. Nothing's pathognomonic. So Robinson Guzay articulated a set of variables that we need to consider, which are very easy. What's the age of onset of the illness? Age of onset is earlier in bipolar on the average. I call it the 75-25 rule, that 75% of people with bipolar start the illness before the age of 25.
That's right.
Then you look at the phenomenology. Now, we just made the point that nothing is pathognomonic during depression, but some features differentially affect depression and bipolar, such as atypical psychosis and mixed features. The other part is family history.
Absolutely.
All the variables. Family history is probably your best predictor that depression is more likely bipolar than it's not. And then also you look at response to treatment. And response to treatment obviously can give you some indirect clues as well. This is very easy to do. So, for example, when I have in my office, here's a very common situation, Andy, you know this. Patient is referred, and the query is, is this bipolar? There's this long drop-down menu of other queries. Like,
that's right.
The borderline personality.
Yeah, exactly.
And so, in that case, what I try to do is go back to what is the fundamental phenomenologic disturbance. This is just me speaking, just conversation as a clinician. So, now everyone has their own sort of artistic way of thinking about bipolarity, but I've often seen it as a dysregulation of rhythm of mood, rhythm of cognition, rhythm of behavior, of sleep, of biology. You name the rhythm, it's a dysrhythmia.
Exactly. That's right.
I don't see ADHD as a rhythmicity disorder. Not primarily. Do they have rhythm problems? Absolutely. But ADHD, in my, this is the way this is just my little cheat sheet at the clinical sort of point of contact.
Yeah.
I see ADHD more in the cognition area with manifesting behavioral aspects. For borderline personality disorder, I've seen this, I don't want to be too kind of psychodynamic, but this sort of in the object relations Melanie Klein world,
Yes.
I see this as an attachment, or use Bowlby's work and so on.
Completely.
It's an attachment problem.
Absolutely. Fear of abandonment. Absolutely.
It's abandonment. It's closeness, distance, struggling. These folks have closeness, distance, struggling. They cannot attach securely.
I had a professor, Roger, you're going to love this, who said, "Get away closer."
Oh, that's a fantastic phrase. I'm going to use that. It's a fantastic phrase.
Yeah, go ahead.
I love it. And so, again, these are not diagnoses of exclusion, obviously. You can have,
That's right.
no cut. And I'm obviously being overly reductive. But I do think that the phenomenologic core is a little different. And again, it was it's one of those kind of things that we just have to take the time to, of course, time is precious, just to kind of suss that out and parse that out in the patient. But I think it does kind of show itself over time.
Roger, that was a beautiful answer. I completely agree with you. And of course, you and I, 15 or more years ago, did a series of talks with our friend Sloan Manning in which we used that exact framework you're talking about. And I think that the age of onset is great. If your first episode is before the age of 25, it turns out Washington University in St. Louis plays a role in what I'm about to say here too. This was Barbara Geller and colleagues. If your first episode is before 25, that actually triples the odds that you're bipolar. And as you said, 75% of people will present there. Second one, genetics. Bipolar is even more highly genetically loaded than unipolar MDD, which we know has some genetic underpinnings. And finally, I raised Sloan Manning to give us the quote, his famous quote, which summarizes the response to antidepressants, which he called antidepressant misadventures.
Oh, that's a great one.
Isn't that
really a great
I love
one.
that. The other thing, Roger, he taught me, which is related to your dysregulation and rhythm, he taught me that, yes, it's an illness of mood swings, but it's also an illness of energy swings. And I've got to tell you how helpful that clue has been when I ask people, you're depressed now, you're slowed down, it's hard to get out of bed, feel tired. But how about in the past? Have there been times when you had a lot more energy, didn't need as much sleep, had a lot of great thoughts or ideas, and that will get it.
Yeah,
sometimes.
Absolutely. That's a very good point.
Yeah.
Again, it goes back to, that famous quote from the famous physician, Sir William Osler, who may be less familiar to some, but he had the famous quote that just listen to your patient. He, of course, this was back in the 1900s, he is telling you the diagnosis. But
yes.
I think it's about listening. And I think the energy piece is well taken. And I think that there is, and again, I'm guilty of being overly parsimonious, but I think that there's a dysregulation of the very core faculties that subserve energy, subserve arousal,
motivation, reward,
subserve cognition, behavior, and so on. And so with bipolar, you get this kaleidoscope of psychopathology. But if you take your scalpel and you cut deep into the wound, you'll see at the very core, I think, dysrhythmia. And what's interesting is that evidence shows at the cellular level, there's something wrong inside the signal transduction cascades with their rhythmicity. And lithium, which is obviously still a gold standard mood stabilizing agent,
yes, it is.
It actually corrects the rhythmicity right at the cellular and the molecular level. So it's pretty cool.
Yeah, I like to conceptualize the bipolar brain as dysregulated and not well buffered. If it gets thrown off easily, it's like a car that goes off the road really easily with a little bit of wind. So these are all very helpful clues. I think the energy swings thing, also DSM-5 agrees with you and me, Roger, because DSM-5 added to the criteria for a manic episode and, of course, mood, elevated grandiose irritable mood, and increased energy or activity observable by others. So now we also have an objective component that allows us to ask family and collateral people. So I think that was an extremely helpful change as well. All right. Let's shift now into some strategies to improve our screening and diagnosis. And Roger, you've been very involved. Actually, you're the primary author on the development of a newer scale called the Rapid Mood Screener. Can you talk a little about that?
Happy to, Andy. And, I think that there are a set of guiding principles around the whole topic of screening for medical conditions. Mm-hmm. And we do it in clinical practice to obviously increase detection, accurate case detection. At the end of the day, it's not about identifying more people. The purpose of screening is to improve the health outcome and the cost effectiveness of our care. And what everyone agrees is that we shouldn't be screening for things that we can't treat. Will be the point. We should screen for things that we have the treatments, the infrastructure, the resources to treat. So that's the first point. Second is that for reasons that you already got into, there's lots of reasons we should be screening for bipolar disorder, given the misdiagnosis, the delay in diagnosis, confusion with other diagnostic entities. And there's been over the years more than half a dozen screening tools for bipolar disorder. And these screening tools, some are better known, like the mood disorder questionnaire or the patient mania questionnaire, or maybe the hypomania checklist. Others would be a little less well known, like mood spectrum type questionnaires, and there's a few others. And we get a survey a few years back, and we've reported this fairly recently, that there seems to be a fair bit of awareness of many of these screening tools, but they weren't being implemented. And when asked about why the gap between knowledge and implementation, people often would say, well, they don't really help my workflow. They don't help my patient journey. In fact, if anything, they kind of throw a wrench, because a lot of patients are screening positive when they don't even have the condition, so-called false positive. So we went back and we said, hey, we don't want to throw the baby out with the bathwater. We want people to screen. Maybe we can do better on the psychometrics. So we iterated, we originated, and then we validated the rapid mood screener. And the rapid mood screener has been validated in adults with bipolar 1 and bipolar 2. We recently validated bipolar 2.
Yeah, that's newer.
It includes 3 questions around mania, 3 questions, hypomania, mania, 3 questions around depression. And when we look at, Andy, there's the sensitivity, specificity, negative, positive, predictive value, all that kind of psychometric kind of stuff. It does as well, frankly, better than all the others that were out there. And of course, that's good for the classroom, but in the real world, it seems to be delivering. And I think the most important thing about a screening tool, in my mind, Andy, is does it have good negative predictive value? In other words, if a patient screens negative, can I be reasonably confident they don't got it? And the answer is yes. We got really good and negative predictive value NPV. The positive predictive value is also very good. But to make the point very clear, a negative and positive screen don't rule out or rule in. They triage you, if you will.
That's right.
And so time is short. If a patient screens negative on the rapid mood screener, I can be confident that maybe I don't need to go through half an hour of questions with them on bipolar. If they screen positive, I'm going to need to really get my sleeves rolled up and ask them more just to confirm that diagnosis. So that's what I would recommend. And I think it should be routine in clinical practice. You point earlier that we should assume all depression's bipolar to prove it otherwise. I completely agree. And I think this is why they should be screened.
Yeah, that's right. Yeah, so the kind of the gold standard before this, which was given out by pharmaceutical companies, was the MDQ. 13 questions only on manic symptoms, which I always found a little troublesome. Because people are not good at reporting mania. So I used to actually tell the patient, take this home and think about it, or ask your family member, and they would come back after a couple weeks and say, well, now that I thought about it, I actually do have some of these, whatever. But it was also, I looked at it more like a discussion starter. But this RMS, which is now only 6 questions, and as you mentioned, brings in depression, which people are a little more in tune with and able to talk about. Now, a positive screen is 4 out of 6, but I have to tell you, Roger, if somebody gets 2 or 3, I am still going to dig a little bit. I'm still going to, it's a conversation starter.
Oh, I do think that's true. I do think that's true. Yeah, absolutely. It's a bit like, you can kind of imagine, some people who have an impaired glucose level, but it's not threshold for diabetes.
Exactly.
I don't think people would walk away from that as being benign. It could be just one of those just blips on the curve, and it may not be nothing. But I think most of us would approach a pre-diabetic glucose level as a little bit more concerning, and we'd keep a closer eye on that. So I agree with you. And these lines, like 4 out of 6, that didn't come down from Moses. That came down from a statistician. And so nothing, it's just, we have to draw the line somewhere on the basis of sensitivity, specificity. And that's a statistical question, an analytic question. And if you required all 6, you would have great specificity.
Yeah.
But you compromise other aspects. So
Right.
So 4 of 6 was the Goldilocks is porridge. That was the right temperature. But I agree. 2 or 3 positives, I would also probe a little deeper.
Well, and that gets to the point that this is not a diagnostic tool. It's a screening instrument, if you will.
Yeah.
I think people confuse that. Again, the diagnosis is a clinical diagnosis, and this is just one tool. This would be like getting some blood work. You know, you wouldn't just make a diagnosis necessarily based only on blood work or only on one blood pressure reading, if you will. You know, you have to do a whole lot. Okay. Let's talk also now about some really important practical things. Some people get confused. How do I differentiate? You actually talked a little bit about this before, but how do I differentiate bipolar from some of the comorbidities like substance abuse, PTSD, those kind of things?
Yeah, and this is so common. I mean, this is such a critical issue. And Andy, just to a point earlier that the comorbidity can often obscure the underlying bipolar disorder. That's pretty common, actually, unfortunately. And the other part is that if you and I were to take, let's say, just identify 100 people living with bipolar disorder who had one episode of mania or hypomania, and then we compare them to another group that had, say, 5 to 10 episodes, the latter group, 5 to 10 episodes, would have much more comorbidity. So,
interesting.
That tells us that some of this comorbidity is preventable. That's kind of interesting. That's one point I would make. The other point I would make is, again, this differential diagnosis is a differential diagnosis. It may not be a diagnosis of exclusion because you can have bipolar with ADHD or borderline or binge eating or an anxiety disorder.
Of course.
And those people do. So that's where we have to just be aware of the diagnostic permission. Of course, you could not have unipolar disorder and bipolar, or you could not have schizophrenia and bipolar.
Yes. Well,
I still see patients who are referred to me. This patient has schizophrenia and bipolar. You can't have both of them.
I see it in records all the time. Medical
Yeah, absolutely. So again, it goes down, this is the sort of, the William Osler, just to listen to the patient. Yeah. And I think for me, it's a great, and I've been doing this for so long, Andy, like yourself, and I'm just like, to this day, it's still the back to the home base of Robinson Guzay, age and on, phenomenology, illness trajectory, family history, response to treatment. Now, that doesn't always sort it out. It sorts it out most of the time. And I have many patients who will leave my office after a consultation, and I'll say, look, I'm not sure whether this is, another one is complex PTSD, Andy, because, that can sometimes present this way too. Or a lot of people, young men, but women as well, who have traumatic brain injury. A lot of times it's not clear whether they have bipolar or not. And heck, we just be frank with our patients. We don't know. We give them a very, very thorough evaluation. But some patients that I say to them, I think you're going to lose confidence in me, but I don't know what your diagnosis is. I think, and we'll go with a working diagnosis. It's a working diagnosis. And I think, so it comes down to that Robinson Guzay, and of course, be aware of the DSM criteria, and et cetera. And the one final point about that, along with, first of all, be aware that comorbidity can obscure. Comorbidity is not exclusionary, it's a core feature. And that is I think that for me, if a patient came to me, Andy, and this is all the time, when I first started, drug and alcohol abuse in bipolar, which we know is very common, a lot of folks would say, I'm not going to treat your drug and alcohol abuse until you get your bipolar sorted out with Dr. McIntyre. And then, these patients would just get bounced around and so on.
Yeah.
The field has moved away. That is such old thinking. We got to manage all these conditions at the same time. Right? Now, there's some nuance to this. For example, a patient came to me, they have bipolar. I'm not entirely clear, Andy. They may not have ADHD. I'm still not entirely clear. Right. What I do in those cases is I want to treat the bipolar to the best I can to get everything stable, so that any of the cognitive distractibility and all that, maybe that's just mixed features. I don't know. Right. And then, so to give you, it's almost like a clean slate. I'll have a cleaner slate to work with once I get the bipolar treated, if you will.
Yeah, that's great. And I get asked all the time, in kids, how do I tell if it's ADHD or bipolar? And the question what I go back to is the oath we all take, which is, of course, primum non nocere, first do no harm.
Yeah.
Well, how do I do more harm? Well, if they're bipolar, but I think they're ADHD and I give them a stimulant, right?
Yes.
So I would go for the mood disorder first and see what's left, if you will. I totally agree. I think this is an illness. We have to be humble in the face of the diagnosis and in the face of this illness. And I sometimes call bipolar the great masquerader. And Roger, let's be honest, you and I miss this still all the time. And so I think diagnosis has to be, I like when you say provisional or working. I think we have to have, diagnosis can be fluid. I think we have to be open to changing and evolving our diagnoses over time. So I love the way you're saying that. It's just not kind of binary, black, white, all or none.
Yeah.
Okay.
And the other part which we haven't talked on is something also, and that is that, look, I've had lots of people that I saw in my career who I thought had bipolar disorder.
Yep.
I made the diagnosis. We've been talking about missing the diagnosis, but sometimes we do have false positives.
That's true.
Right?
That's true.
I mean, it doesn't happen as often. It doesn't happen that often, but it does happen.
Yeah.
Where maybe the diagnosis was never bipolar all along. Maybe a more sort of explanatory diagnosis would have been borderline or pathology or complex PTSD. So
Yes.
look, we don't need, what's that phrase that, we don't need to be perfect. You want to do as best you can. The other part about this as well is that over the years, this is just kind of a clinical reflection. I'm starting to feel like a fossil doing this so long. And that is that I have people I've been following for years, like literally for almost 30 years. And they have classic bipolar 1 disorder. They are bipolar disorder, they had elative manias and so on. And what I've noticed over the years, in some, less than 5%, but some I've noticed something. I've noticed that they start having an appearance and a way of presenting that looks a little more like schizoaffective disorder.
Mm-hmm.
And they tend to have more enduring psychosis that endure beyond the presence of the mood symptoms. So some of our colleagues who are joining us and listening in are probably seeing some of this too. So just to be aware, this is Mother Nature. But I think that's not that common. It happens sometimes. Right? The big issue is missing the diagnosis of the front door.
Yeah, I think you're right. I'll tell you a quick story, though. I saw a woman several years ago who was told she had bipolar disorder. She's going on with this diagnosis of bipolar. She was taking divalproex. And it turned out the diagnosis was made on one complaint only, and that was I have racing thoughts. And it turned out she had an anxiety disorder, Roger, and she was ruminating and perseverating, and that was it. It was not bipolar. So we have to be very careful that we don't overdo it based on just one or two things. Again, what we're saying is this is a clinical diagnosis taking everything into account. All right, there's something we haven't talked about, kind of an elephant in the living room that we've got to confront, and that is mixed states and mixed features. We mentioned that is really a big clue you don't want to miss. So you don't want to just ask about, in the past, have you had manic or hypomanic symptoms? When you see a depressed patient, don't shut your brain off. Ask, and also, have you recently had blah, 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 blah. So why is that important, Roger?
Yeah, at the end of the day, I think bipolar is, so quintessentially heterogeneous. It's so heterogeneous. And so we're talking, you and I today, about bipolar broadly, but we have individuals, and every individual has a different experience, a different manifestation. And so with mixed features, the overarching aim of mixed, sort of specifiers, there's 10 of them in the DSM, is encourage us to be thinking about phenotypic heterogeneity. I call it deep in vivo characterization of the patient. In other words, are there aspects about their presentation, some of that kind of fine-tuning that might affect, first of all, risk assessment, that may affect care planning, that may affect aspects of locus of care, that may affect aspects of what treatment you're going to pick? And the answer is yes.
Exactly.
The best example for me is psychosis. Everybody knows that a person who's got psychosis while depressed or manic, that's a different conversation than someone who doesn't have psychosis for reasons that are abundantly obvious.
Of course.
Now, I think we've made that case strong. I just don't think we'd emphasize as much the importance of mixed features and anxious distress, because if you have mixed features, which is one of the other specifiers, it matters. And it matters in the sense that, if you have mixed features while you're depressed or hypomanic or manic, you are much more likely to have a more severe illness, more likely to have ideation and thoughts of suicide and attempts suicide, more comorbidity. And, we live in a world, Andy, where people, in fact, struggle to agree on anything anymore, but we agree that antidepressants should never be used there. They should not be used there. And as it could make it worse. Finally, these folks, what does every patient ask us? What's my prognosis? And we try to provide the best answer. Well, we do know that if you have mixed features, your prognosis is more likely to be unfavorable unless you're on the right treatment. You got to get on the right treatments here. So this isn't an academic, it's not an academic point. This is a fit for purpose point. So I think this is why it's so critical to contemplate psychosis, contemplate mixed features, and the same comments for anxious distress.
I completely agree. That's a different way to... As a matter of fact, I mean, you and I are fond of saying now, if you see mixed features with a depression, whether you're clear it's bipolar or not, that patient should get an atypical antipsychotic.
Absolutely.
Not do well with reuptake inhibitors, right?
Absolutely.
I think that's a key take-home message. And then also, the presence of mixed features with depression, as we said before, is a clue to the diagnosis of bipolar. Not diagnostic.
Absolutely.
Now, this is an interesting point that I complimented the DSM earlier, DSM-5, Roger, about adding energy. I've got it now with one hand giveth, one hand is going to taketh away. I have to slam the DSM for what they did with mixed features, Roger. They actually excluded the three most common symptoms, right? They excluded
absolutely.
3 of your 4 A's, Roger.
Exactly.
Can you talk about that?
Yeah, absolutely. So, for our colleagues joining us, mixed features is codified. It's all spelled out in the DSM and the definition. Right. Conversationally, sort of, just sort of, kind of, water cooler conversation. It's opposite polarity symptoms. So in other words, if you have 3 or more depressive symptoms while hypomanic or manic, or 3 or more hypomanic symptoms while depressed, that's mixed features. So far, that's pretty simple. And I always refer to it as the threads of hypomania in the tapestry of depression, or the threads of depression within the tapestry of elevation, meaning hypomania. Now, if we get into the nitty gritty, the DSM has to be very specific. And there's some symptoms that they just didn't allow as counting in that criteria. And we're kind of laughing together because, we like to talk shop, and we like to have little ways of little kind of mnemonics and so on. And so I was trying to think of a way of, to think about mix. And so I come with the 4 A's referred to as when a patient has anxiety and agitation, attentional problems and anger, anxiety, agitation, attention and anger problems, while they are depressed, which is the usual way it is, that gets me really suspicious they have mixed features. Now, and if you were my examiner for my state board exam, and you said, okay, Roger, what is the criteria for mix? I could not name those 4 because they're not formally in the criteria, but they're the most common features of mix.
They are. That's right?
So then someone might
that resonates with clinicians. Clinicians absolutely resonate with that. The anxiety, agitation. I like to say anger/irritability because that's really what you mean. I think irritability is a word that resonates with people, and intentional distractibility. Now, you brought this out in your article that I mentioned at the top of the broadcast, so I want to once again give you a plug. I'm not getting royalties here, but Roger's article called Bipolar Disorder, simply 2020, The Lancet, he talks about that. Anyway, so the problem then, DSM excludes 3 of those, other than anxiety, but the other 3, because they say they're non-specific. Well, if you use the DSM criteria, only about 30% of a bipolar's depressive episodes are mixed features, but if you use the research criteria, including those, it's over 60%. It's
right.
More than
Absolutely.
That. So that's why I resonate, towards that. And I think what you did was very helpful there.
Yeah.
Okay. Let's move into treatment planning with the time we have left. I know our time is a little limited here. So I think an overarching principle, Roger, is when you've made this, any diagnosis, you should start with an FDA-approved treatment. I just feel very strongly because there's evidence it can work, there's evidence it's safe. That doesn't mean that's where you end up, because there are drugs, of course, we know are evidence-based that can work that are not FDA-approved. But I think a lot of people are fuzzy on the FDA approvals for medications to treat bipolar disorder, especially the different phases.
You hit the nail on the head, Andy, and I think this is what we call the implementation gap, the gap between what our knowledge tells us what we should be doing at point of care and what's actually happening. And there is a disconnect. In study after study shows that adults with bipolar who have access to healthcare, who've been diagnosed with bipolar disorder, that's the diagnosis in the chart, continue to receive treatments that don't align with what you mentioned, FDA-approved treatments. And this isn't like, once in a while. This is actually, and frankly, almost the rule, not the exception, which is very concerning. Yeah. I agree. I think that, you see, in schizophrenia, I'm going to say it's a little easier because there's one core type of pharmacology. It's an antipsychotic. Similarly, bipolar depression, it's a little easier. But bipolar, you've got such mechanistically dissimilar treatments across different illnesses. And I remember when I was a medical student, learning steroids to treat all the millions of dermatologic problems. I remember the dermatology professor just said, just know 1 or 2 steroids and you'll be fine.
That's right.
It's not good enough just to know 1 or 2 drugs in bipolar, unfortunately. You're going to sell your patients short. You have to know a bit more detail than that, because not all the atypicals are approved in bipolar depression. The other part is that for me, I think, Andy, there's been a tectonic plate shift. We no longer think that bipolar is just an episodic illness. We think it's an episodic and chronic illness.
Yes.
And in keeping with that view, I think that the selection and the sequencing of psychotropic drugs for bipolar, obviously efficacy's got to come first. We got to have tolerability, not just in the next 3 days while they're an inpatient or if they're in the acute care or what have you, but what treatment has shown long-term efficacy? What treatment has shown efficacy in aspects that are most relevant, like depression? So things that jump out for me is this treatment effective for depression in bipolar? That's a key issue. That's the enemy of the state in bipolar. Second, is there any long-term data? If I get both, I'm happier. I'll take one or the other. And I think we need to think long-term, not just 3 days, 3 weeks.
Yes, and that's another good point. Not only are not all the atypicals approved for bipolar depression, they don't all have a maintenance approval. Although generally, as we know, what gets you better keeps you better.
Yeah.
And you brought up tolerability, but I want to make a distinction between tolerability and safety. And tolerability is kind of immediately things that are annoying, nausea, and so on. Safety is more of a long-term, except for anaphylaxis, but longer-term things like, weight, glucose, lipids, so on. So I think we have to take that into account because this is a chronic illness. We want our patients to keep taking the medicine. And as you also well said earlier, there is an independent, highly genetic association with obesity, cardiovascular, and diabetes. We don't want to necessarily add to that burden.
Oh, absolutely. This is actually such an important point. Andy, this has been my kind of soapbox for a long time.
Yes.
I think when I first started, you first started, Andy, we're about this similar when we started our careers, and we had that many options for bipolar than FDA approved, really.
No.
The good news is we've had more treatments in the last, say, decade we've had in the last 10 decades combined. We've had treatments, but they are different. And I do think that in today's, pharmacopoeia, the options we have, there are clear differences in their efficacy in bipolar depression. And we need to be aware of them.
Yes.
That's such a critical problem. In bipolar 1, bipolar 2, there's differences now.
Yes.
There are clear, not nuanced, differences in metabolic and weight gain.
Yes.
And I think, this may be an overly maybe this is not quite the point I'm trying to make, but I think it is that if I was a diabetic person and I went to a clinician and they said to me, I've got 2 treatments for your diabetes. One is weight neutral, but it'll help your sugar. And one will cost, 20 pounds and 30 pounds of weight, but it can still help your sugar. Which one do you want? The patient, Are you for real? Are you for real?
Yeah.
So, I mean, and I think that nobody wants to have those types of medications. We got to give priority, I think, to treatment with the efficacy, clearly, FDA indication. I think depression's the enemy of the state. I keep emphasizing that. And obviously that don't cause these treatment-limiting side effects. I think that's, some might say, well, this kind of seems like basic advice. I'll say guilty as charged.
Right.
But it's not happening.
Right. Well, I think we have some newer medications, too, that are less likely to add to this burden.
Yeah.
And we have some interesting strategies and combinations of things. There is one medication, for instance, with a very effective older antipsychotic where an opioid blocker has been added and has been shown to mitigate the risk of weight, which I think is very interesting because it shifts the benefit-risk balance more in favor of benefit, less risk.
Absolutely.
And then, of course, we know a lot of us use metformin, for instance. But now, of course, there's the GLP-1 agonist, and we don't have time. You and I could go on for a long time. We've been very excited about the repurposing and all of that. But there are ways potentially to manage. Of course, exercise, which you mention all the time. And I don't think we should give up on things like dietary intervention and lifestyle. You and I were talking just yesterday about the metabolic complications of sleep disturbances, so managing sleep and so on.
Yeah, absolutely. And that's such a nice point. And that is that, you kind of go into this with your guiding principles, what treatments are FDA approved for bipolar depression. We have treatments now for mania and long-term that have less weight gain. And you mentioned there's weight mitigation strategies there, which is interesting and great.
Yep.
But also, what treatments do I need to consider for my patient who has, as you said, sleep? Some of these patients have ADHD or binge eating and so on.
Yes. Yeah.
The other part to this is I'm going to put a little plug in for DBSA, Depression Bipolar Support Alliance, and peer support, and for family experience at www.dbsalliance.org. And I think that's underemphasized. It's a great source of literacy enhancement of illness and treatment, as well as support. The other issue is that I do think, where applicable, where available, where motivated, in some cases, manualized based psychosocial interventions, like CBT, mindfulness groups, psychoed, even family, be very helpful added to. But again, I appreciate that there's often aspects about access and availability. I got that with that. So that's something we put out there as well. Just on a parenthetical note, Andy, what I've been particularly interested in as well is whether, would exercise help patients and other things. Well, those are more experimental. In a sense, we haven't studied them enough, but it's something I've often wondered about as well,
Mm-hmm. Well, there, of course, are data on exercise for depression and improving mood, and it stands to reason exercise is going to improve, you'll lose weight and improve your metabolic state and so on, which, it's anti-inflammatory and so on.
Yeah.
I want to put a pin in something you said about DBSA, because I actually, Roger, give this out to every patient and every family member, and the website is dbsalliance.org. It's the Depression and Bipolar Support Alliance. Roger's modest. He's the chairman of is it the Scientific Advisory Board or the board?
Oh, the board, yeah.
The board, my goodness. So he's been very involved. And this comes back to diagnosis, Roger. A lot of people are afraid to make the diagnosis, afraid the patient will get mad at them. And I say, I make it the best day of their life. This is why you haven't gotten better. And the good news is this is compatible with a full life, but we need to get the right treatment. And now we're going to get the right treatment. And then I give them this, and it really helps the patient to buy in and helps with adherence, but also helps family members, because they always wonder, what should I look for to see if they're getting worse? And what can I do to help them? And this website has a lot of tips for family and so on. Roger, with the minute or two we have left here, quickly, we've got to talk about the Therapeutic Alliance and motivational interviewing and shared decision-making. Can you maybe put a coda on that?
Yeah, I'll keep it brief. It's so critical. It comes down to often this is the deal breaker. Do we have a relationship with the patient that's meaningful and productive? Is that relationship one that is truly a relationship that's a shared decision-making process? And I think this is absolutely critical, and it is a tremendous predictor of more positive experience of the patient and family. I've often seen myself, and this is what I've kind of embraced this very early in my career, because I sort of see myself more as the advocate to help patients around the area of literacy and support. But again, we have to set goals, and, we use the SMART acronym, specific, measurable, actionable, realistic, time-based. You have to have clear goals. And I think that's critical. In fact,
that's right.
I think setting goals is psychotherapeutic in of itself, right? And then you have to have that. And I think it's part of, it has to be patient shared decision-making. That phrase that, decisions about me should involve me. And I agree with that.
I like that.
And so that's a critical part. It's self-efficacious, it's validating, but they should be partners in this experience. I think that's something we strongly promote as well at DBSA.
Could not agree more, Roger. And boy, I just feel like we could go. There's so many other things we could talk about. We just barely scratched the surface. I do want to put a plug in for, if you want to hear more, please come and see us. You can see Roger and I live, and you can actually talk to us. Come right up to us, ask us questions at our NEI live meetings. We love engaging and trying to help our colleagues. We have 2 meetings a year, of course, the Congress, which is coming up in the beginning of November, and what used to be called Synapse is now going to be called the Spring Congress, and the one coming up is the Fall Congress. For more information about our educational offerings, please go to our website, neiglobal.com. And Roger, as always, I really enjoy our ongoing, now many-year conversation. Thank you so much, and I hope this has been helpful to our audience. Roger, thank you.
Andy, personally, always fun. We've been doing this a long time. Still surreal we get to do something that is so personally enjoying, and professionally, of course, it's just a bonus. It's a lot of fun. Thanks to our colleagues joining us. Indeed, come up and see us, Danny and I, in vivo, in real person.
Yes.
I always love our meetings, and great to do this. Have a great day.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.